It is my pleasure to welcome Dr. Goldberg, an interventional cardiologist at Lund University. Today, we'll be discussing his JACC interventions manuscript, reporting the long-term outcomes of IFR versus FFR coronary revascularization, an insight from the SWEDEHEART National Registry. Dr. Goldberg, thank you so much for taking the time to join us and share your expertise.
Great, thanks. Great to be here. Thanks for having me.
First, can you give us a brief background about the topic and the question that you aimed to address?
Thanks. I guess you and the audience probably know about FFR, fracture forward reserve, but I thought I'd give you a little bit of background. FFR is obviously wire-based hyperemic index, so it uses adenosine to assess lesion severity. In other words, whether a lesion needs revasc or not. And obviously, there have been numerous trials showing that FFR is better than using eyeballing, alone. So FFR has been around for like 30 odd years now. And 12 years ago, back in 2013, IFR was approved. So IFR, or instantaneous wave ratio, is a resting index. And with that comes certain benefits. I mean, first of all, we don't have to use an adenosine. So there's no patient discomfort. It's actually quicker and there's no lesion crosstalk. In other words, it's actually easier to assess serial lesions independently of each other. And back in 14 and 15, there were several comparative validation studies published that showed about an 85% agreement between IFR and FFR, and also similar ability to detect ischemia when using other indices as an arbiter. But there are obviously no outcome data back then. So we conducted two different studies. The first one was Define Flare, which was a 2,500 patient global study. And I was fortunate to be PI of IFR SWEDEHEART, which was a 2,000 patient Scandinavian study. And these two studies were published back in New England Journal of Medicine in 2017. This was a one-year result showing overall similar outcome in both these studies, so very concordant results. And then a few years back, we showed the 5-year results from IFR SWEDEHEART showing that there was no difference in MACE or any part of the components of MACE. In defined flare, however, there was similar MACE, but an increase in all-cause mortality in the patients in the IFR group, which was 9% versus 6.2% in the FFR group. And this was statistically significant. This was weird because this was restricted only to deaths, and there was no increase in myocardial infarction or revascularization. And the other thing is was restricted to treated patients. So if I switch it around, we found these results odd because if when you compare to diagnostic indices, I think that IFR, if IFR would be worse, it would probably only mainly affect revascularization, possibly MI, and barely death. And the other thing is probably it's unlikely considering that the overall agreement between the indices is 85%. So a difference of 15%, a disagreement would not drive mortality alone. And third, I guess also the fact that these were if it were a worse index, it would probably affect the deferred patients and not the treated ones and not mortality alone, as stated. So what we did was really that we went back to our registry. And for those who are not aware, in Sweden, we have unique personal identifiers. Think of them as social security numbers, but they're mandatory. And these are coupled with the quality registries and population registries, which we do have in Sweden. It essentially means that we can track every single patient from the cradle to the grave, and we can do meaningful research from this. So we can do observational research that essentially means that we don't lose any patients to follow-up. And this is actually better than we see typically in randomized clinical trials, where you typically lose about 10% of patients to follow-up. So we did this study together, my colleague Mohammad Mohammed, associate professor of my institution, and myself. We looked in the SCAR registry, which is the National PCI registry, and then we linked these to the National Patient Registry and Cause of Death Registry. We wanted to look at the kind of long-term outcome comparing IFR with FFR in a clinical setting. So first of all, we didn't really have any patients lost to follow-up. We presented some of these data as late-breaking clinical trials at CCT 1.5 years ago. And what we did that we had a full patient cohort of almost 43,000 patients. And we looked at those specifically, but we also did 2-to-1 propensity score matching and 1-to-1 propensity score matching. and the 2-to-1 propensity score matching was almost 25,000 patients. So think of them 5 to 10 times larger than the randomized clinical trial data. And this would really give us the power to detect any possible difference in mortality. So, what were these results of the study? So, the 5-year event rates in terms of MACE, which was death, MI, or revasc, was 31.3% of the patients in the IFR group versus 31.9% of the patients in the FFR group. So, really, no difference between the two indices. The hazard ratio was 0.95. And then we looked at the components of MACE, death, MI, revascularization, and there was no difference at all between the two indices. And then also looking back at the 1-to-1 propensity score matching and the full cohort of
Mhm.
43,000 patients, was really no difference between the two indices, neither when it comes to MACE or the components of MACE either. So we really couldn't replicate the findings in defined flare. And
Thank,
so really
yeah.
showing that both of them do very well together.
Thank you so much. I think it's a very nice to set the stage and share with us the results. How do you think do we move forward giving these results? Do you think we're over the IFR versus FFR debate?
I really hope so. I mean, both these indices have been around for many, many years now. They're both in clinical practice. They're mostly the same. There's small differences, but overall, I think we've repeatedly now shown that there's no difference in terms of outcome. So you can use either one in your clinical setting, which one you prefer. But I really hope that this settles the debate.
Yeah, I completely agree. And thank you again, Dr. Gothenberg, for joining us today. And we invite everyone to go over the full manuscript published in this issue of JACC Interventions. Thank you again.
Thanks.